Hello everyone. Today we are going to do another quick lecture here. With all of these STI, STD, sexually transmitted infections, sexually transmitted disease lectures for studying purposes for me, and I'm sorry if I'm repeating myself because I think I'm going to do this in the beginning of each one. Please make sure you study the bug and the drug. So bug, drug, bug, drug, bug, drug. Hopefully easy to remember, but basically just want you guys to know the number one first line treatment for these STIs. So for exam purposes, again, number one first line treatment for all of these bugs, know the drug. So first off, we have Trichomoniasis. Well, first off for me, I'm just recording this in this order, but you guys can listen to them in whatever order you want. But so we have today, I guess I should say, Trichomoniasis, also known as Trick. I remember in pharmacy school, I was like, what'd you say about my mama? We might have to go to toes. Why are you saying trick? Who are you calling a trick? No, but that was an unprofessional joke. But yeah, that was something that we were told in pharmacy school. So you may hear it referred to as trick, Trichomoniasis. Let's get into it. So this is the bug here, Trichomoniasis vaginalis. So it's the most common non-viral STD in the world. I wish sometimes I could do like an echo effect on here, but I can't. I'm not that fancy. Maybe next year if I keep doing this, I'll do like all these sound effects and stuff. Unfortunately, women are more affected than men, and it is one of the three major causes of vaginal complaints. It can also cause urethritis in men. However, for both men and women, the infection is often asymptomatic. So that's part of the reason why it's so prevalent worldwide, is because a lot of people don't have symptoms. And by the way, too, so some of this is going to be kind of overlap from PathoPhys and from your ICM course. But like I said, testing purposes, bug and drug. And I say bug, but I just mean if a patient has Trichomoniasis, how do you treat them? That's what I meant. I mean, I'm going to give you guys the diagnosis in these questions. I'm going to make sure you guys know what bug we're dealing with. So it'll be explicit in the question. The patient has Trichomoniasis, and then what's your first line? So hopefully that'll help. All right, my computer's acting up again. Okay, there it goes. Sorry about that, guys. So like I said, it's caused by the Trichomoniasis vaginalis. Up to 70% of male sexual partners of infected women. So co-infection is an issue, which we'll come into later when we talk about the treatment. It is important to treat. If not, you can get urethritis or cystitis. Also have some adverse reproductive health outcomes. You guys can read through those. Also increase women's risk susceptibility to HIV infection. Like I said, most people are going to be asymptomatic, but then they can have acute severe inflammatory disease. So this is where you have that. It's kind of textbook discharge that apparently has a certain smell to it. I luckily never had to smell it before. My wife says it has a particular smell. And that with the men, they are more likely to be asymptomatic, but then they'll have the urethritis, so they'll have complaints of pain, discomfort. As far as the diagnosing goes, I just put this here for completeness sake, but you just go ahead and read through this. This isn't anything I will be testing you guys over, and this may be beneficial for your ICM course. Same thing here, just FYI for my course, don't worry about it. Treatment is indicated for both symptomatic and asymptomatic men and women, so that is important to note. So especially too when you're talking about partners, so sexual partners, if the man's like, well, I don't got it, I don't feel like it, or the woman's like, it is important to treat both, so even if they are asymptomatic. So for non-pregnant women, definitely put a star by here, and their sex partners, single dose, 2 grams of either metronidazole or tinidazole. So definitely put a star by those. I want to make sure you guys know. Single dose therapy is more convenient, and it does seem to be as effective as multiple dose therapy. So that's nice as far as compliance and making sure the patient's getting treated. And typically, by mouth administration is preferred over topical administration. So they do make these as like a vaginal cream, for example. But just go ahead and go PO route by mouth, 2 grams, one-time dose. Bam, knock it out. Hopefully it knocks it out. I typically see the Flagyl, which is generic for metronidazole, prescribed more, but either one. So definitely make sure you're studying those for exam purposes. The patient should be screened for other STIs. It's also important, like I said, that the sexual partner is screened and treated, and then also looked at for other sexually transmitted infections. So if there is an asymptomatic pregnant woman, you can also go with the metronidazole, 2 grams one time, so 2 grams by mouth times 1 dose. Or you can, for the pregnant woman, you can stretch out the treatment to 5 to 7 days. So you can do 500 milligrams BID, 5 to 7 days. This may help mitigate nausea and vomiting. So that may be a reason, especially if the woman has problems with morning sickness, nausea, vomiting. Because basically the idea is if you give the 2 grams and they throw it all up, they're not getting treated. So that's the rationale behind that. But just so you know, as far as evidence-based medicine is concerned, either regimen is acceptable. So, it's just really if the nausea vomiting is an issue and the woman isn't able to tolerate the 2 grams at one time. If there is an HIV positive woman, you can also go with metronidazole, but you do want to make sure you give the 500 milligrams BID for 7 days. And so this will be an instance or a reason why you would not give the one-time dose of 2 grams. And then if a person does have refractory trichomonas, you basically stick with the same 2 drugs. So that'll help with studying purposes. But you increase the dose and you increase the duration. And that's going to depend on the patient as far as how high of a dose you go and also the duration, what else is going on with the patient, how many times have they been infected with it, how refractory is it, etc. So for my exam, don't stress about that. And if there is anything like that, it's going to be really clear cut for my exam. And so hopefully by this point, you guys know with my exams, I try not to play the gotcha game, trick you guys too much. And it'll be straightforward and clear cut as far as, like I said, they have trichomonas. What's first line? Probably Flagyl, right? Metronidazole. Okay. It is important, this is patient education, that the patient should avoid intercourse until they both have been treated, that both of them and their partner, and they are asymptomatic. It's typically about a week. Tell them to cool it down, cool it off, or whatever. Just hold off from sexual intercourse for about a week. For the women that are documented with the infection, they should be retested within 3 months. And to see if they have, if the treatment was successful or not. But you can retest as soon as 2 weeks after completing their treatment. And that is the last one for me. Thank you guys for your time and attention. As always, feel free to email me any questions, comments, or feedback. Talk to you guys later. Bye.